So in my disclosures, these are my disclosures, but my bigger disclosure for this talk is that I love stents, but I really hate in-stent restenosis because it's a real problem. Now, we know that nitinol stents are being used more commonly in the therapy of superficial femoral and popliteal artery disease, as well as infrapopliteal disease, as multiple reports have shown improved patency and better symptomatic relief as compared with balloon angioplasty, and you must use them if you have crucial flow-limiting dissections. But in-stent restenosis is common over time, and the interventional therapy of in-stent restenosis has historically been associated with high restenosis rates and complications. Now, why should we even pay attention to this problem? Well, it's a huge problem. We know that peripheral arterial disease is highly prevalent, that many stents are being placed each year, and regardless of how good a stent is used, there will be cases of in-stent restenosis. We talk about restenosis over 1 or 2 or 5 years, but there are cases that don't develop until 10 years post-stent implantation. So this is going to be a problem that even if future stents are perfect, interventionists are going to be dealing with for some time. Now, it's important to understand what restenosis is in a superficial femoral artery stent. It is usually secondary to intimal ingrowth in a fully expanded stent, and reocclusion usually has superimposed thrombus. Several investigators have noted that there's an increased incidence of stent restenosis when stent fractures are present. Now, historically, treatment of particularly long diffuse disease and occlusions showed very poor patency. One study had less than 20% patency in long total occlusions at 3 months, and there were high rates of embolization during intervention. Now, the histology of this problem is that of neointimal hyperplasia is not tremendous cellular growth. It is only about 15% cellular and about 85% extracellular matrix, which has very high water content. Now, why is this important? Well, with balloon angioplasty alone, we initially squeeze this water out of the plaque, as shown in this article by Mentz and colleagues. But if we simply follow this angiographically over 30 minutes, we see that this quickly rehydrates and restenosis may occur. So suboptimal results with balloon angioplasty are common here for many reasons. First off, the angioplasty just squeezes out the water content, which quickly rehydrates. Thrombotic material may embolize, and that material is in and of itself thrombogenic. Because the stent is typically fully expanded, you simply will have no further positive remodeling. Suboptimal results with repeat bare metal stenting within an in-stent restenosis are problematic because of embolization. There's no barrier to intimal ingrowth, and they won't seal pseudoaneurysms when they occur. And the lumen is compromised by at least the strut thickness. Mechanical stabilization of fractured stents with either covered stents or nitinol stents is probably crucial. And now in the US, we have 2 FDA-approved therapies for ISR. Tosaka has shown that long lesions simply do worse, and so we've created this classification. So there are a lot of things to consider before treating these. How long are they? Where is the lesion? Is it a stenosis or an occlusion where there's thrombus? The acuity of the symptoms. Is it fully expanded or is it compressed? Are there fractures? What is the runoff status? What is the location in the artery? What is vessel diameter? Gore did a study called the Viabond study, in which it was called Reline, and in this, the Viabond device was utilized to treat in-stent restenosis. 100 patients were allocated to treatment, and ultimately 39 were evaluated in the Viabond group and 44 in the balloon angioplasty group. And you can see that the Viabond group had a far superior outcome 1 year out with similar rates of complications. And based on this study, the FDA approved this device for treatment of in-stent restenosis. Here you can see primary patency was 74.8% at 1 year versus 28% in that group treated with balloon alone. For some reason, I'm going backwards here. Please forgive me. A lot of things to consider with this. You must avoid oversizing. You have to treat all of the disease. You have to use dual antiplatelets. You must place the device at the SFA origin if disease is present. If you need 2 stents, you must overlap. You must always post-dilate. You do not want to use angioplasty outside of the device. You must follow these patients with regular duplex follow-up, and you must treat progressive disease even before symptomatic. The second device approved is the excimer laser for treating in-stent restenosis. And this is based on the EXCITE trial, which is a randomized, a prospective randomized controlled multi-center trial looking at laser angioplasty versus balloon angioplasty alone. In this case, it was a 2-to-1 randomization looking at efficacy and safety. The baseline characteristics were these were often very long lesions, 20% were greater than 30 centimeters long, and you can see these were particularly tough lesions. In the analysis at 30 days, primary endpoints showed statistical superiority to laser plus balloon angioplasty versus balloon angioplasty alone. And this was maintained at 6 months. And we can see that what was impressive about this data is that if you simply look at the group that was treated with laser plus angioplasty, simply by luck of draw, these patients did tend to have a slightly higher disease, which I'll show in just a second, slightly higher grade disease. So freedom from TLR, high statistic significance in improvement. Freedom from major adverse events, again less in that group treated with laser first. Lesion length and TLR, certainly those patients with longer lesions seem to be the ones that benefited the most from first laser atherectomy followed by balloon. So in conclusions with the EXCITE study, laser plus angioplasty was superior to balloon alone. It's the first FDA-approved randomized control trial showing benefits of laser atherectomy in the lower extremities, and it's the only atherectomy treatment at present approved by the FDA. Here just shows one case of long diffuse in-stent restenosis treated with this device. Another before and after laser atherectomy. There's a new tool that's come out that I think will yet improve these outcomes. It's called Turbo Power. And so instead of leading with a ramp, which is dead space, one actually leads with the laser probe. Now, there's a lot of interest in drug-eluting balloons. These are not yet approved in the U.S. for treatment of ISR, but you can see the trials. And each of these trials, as I just simply run through them, did show decreased restenosis rates, making us wonder, what should we do? Well, Joost Vandenberg here on the panel looked at combining laser followed by drug-eluting balloons. He had high technical success, and his primary patency at 12 months was 100%. And for the duration of follow-up, which was average 19 months, he had 92% patency. He saw one case of restenosis 36 months post-procedure, certainly impressive. Now, the one trial looking at laser plus drug-coated balloon versus drug-coated balloon alone was a single-center study by Dr. Gondini. And you can see here, laser with initial debulking followed by drug-eluting balloon showed substantially improved freedom from TLR, limb salvage, and freedom from amputation. So in conclusions, a new paradigm is emerging for the treatment of femoral popliteal ISR. Balloon angioplasty has failed against 3 different strategies. DCB is effective for very short lesions. Certainly more data is needed for Tosaka 3 and for cost effectiveness. Both laser atherectomy and Viabahn are effective for long lesions and are FDA approved, and combination therapy certainly warrants future and further investigation. Thank you much.